So what we're going to, they've asked me to talk about transition. And transition is the elephant in the room. It's the $25,000 question that none of us have a perfect response to. So what I'm going to try and talk to you guys about today is some reasons why transition is important, some barriers to it, some things that you need to know, some things that we need to know, what we're doing today at Children's Hospital to help with transition, what is transition, and also what the thalassemia nurses, I'm part of a thalassemia nursing group. We get together every month, we do conference calls, and we put together some guidelines on what we think are the important elements of transition that you need to know as patients and that your kids need to know, so that when you have to move around, because not everybody stays in the same place every day, that you're prepared and the knowledge that you have is prepared for you. And those guidelines are not only for you, but also for your providers as well. So let's talk about it. So transition. What is the definition of transition? It's movement, passage or change from position, state, stage, subject, concept, etc. to another. It's change. And everyone knows that change is bad. Bad, bad, bad. Nobody likes change. And the transition from adolescence to adulthood is, I think, one of the most exciting and difficult times in our lives. And that's for anybody, regardless of whether you have a chronic illness or not. But when you have a chronic illness, it adds a layer of complexity to everything that you know about more than I do. As Dr. Coates said, the good news is that we are getting so much better at treating our chronic illnesses and treating our kids that diseases that used to be pediatric illnesses are no longer pediatric illnesses. They are adult illnesses now. They're illnesses that everybody has. In 1999, over 90% of the children born with chronic or disabling conditions survived well beyond their 20th birthday. That's awesome news. In thalassemia, the death rate has dropped by 70%. That's great news. But the number of adult providers who have expertise in these chronic illnesses has not jumped by 70%. I would say it's jumped by 0.01% perhaps. You really don't see you're not seeing a movement in the expertise from the pediatric centers to the adult centers. And this is not unique to thalassemia. We see this in cystic fibrosis, spina bifida, cardiac conditions. We see it in the other rare diseases that we treat in hematology, like sickle cell disease. This is something that's really a very common problem in these pediatric illnesses. So we're trying to find ways to help people in fixing them. And as Dr. Coates said again, we're hoping that with optimal therapy, and a lot of doing that optimal therapy depends on the patient taking their medication, that patients will live near normal lifespans. Well, then how are we going to care for those patients and maximize their wellness throughout the lifespan? So that was the good news. The bad news, as I just said, is that we're just not set up to deal with any of this kind of success. And when I say we, I mean the insurers, the payers, the hospitals, the level of expertise in your providers, and in many ways the patients. We have done such a good care of taking care of our pediatric patients that they don't really want to go to adult facilities. And I really don't blame them, because it's a very hard transition in very many ways. And as we discuss how that care model is different, I can understand why it would be very hard to change. But the reality is that change is the one constant, and we have to learn to deal with that. So what are the barriers? Some of the barriers are patients and parents, and I don't say that in a bad way or a judgy way. It's just that it's hard adapting to a different model of care. It's hard leaving something that has been so successful and moving to the great unknown. Lack of skilled providers and centers. We know that. It's a very rare disorder. Thalassemia is extremely rare. There's only about 1,000 thalassemia patients in the United States. That out of a population of what? 300 million? Sorry, I'm from Canada. I still don't know the population. Canada's 30 million. I know the population of Canada, but evidently not the U.S. And then you have insurance, authorizations. As you know, California is broke. And we have had a lot of changes in the past probably 5 years in how we insure our patients through with the government-sponsored systems. And it's gone very much to an HMO, Medi-Cal HMO, and that's changed how we get authorizations, how we get payment for stuff, and all the loops that we have to go through to make sure that the patients get the best care possible. We are very happy to do that. That's what we want to do to take care of you. we have supports at Children's to make sure that all that happens. A lot of adult places don't have that same level of support. They don't have the village that we have at Children's. We're very lucky that. And we often talk to CCS. Many people are familiar with CCS, California Children's Services. Whenever they start threatening to take away these services, we just had CCS people, government people, come through the hospital recently. And I had a long talk with them about how it takes a village to raise and to nurture and to care for our thalassemia patients and our chronic illness patients. And if they start dismembering CCS and stuff like that, some of that village will go away. The reality is most adult providers don't have that village. They don't have the resources to fund that village. You know, every once in a while at Children's, they threaten to come through with these consulting groups. We're having one come through soon right now. And you never know. Oh, well, they make cutbacks. I remember one time I went to Dr. Coates, and I said, Dr. Coates, you know, there's these consulting groups coming through. And he looks at me, he's like, yeah. I said, if they fire me, you're going to have to do all the transfusion orders all by yourself and all the X-shade refills and get all the prior authorizations. So you better make sure I still have a job. I'm still here. That's all I got to say. But the reality is that I do a lot of this stuff. I mean, in our village, we each have our roles and responsibilities. When I say a village, the patient, the parent, the family, you are part of that, obviously. And we each have to do what we need to do to take care of each other and to make sure that the patient gets the best care possible. But the size of that village depends on where you are and what resources that you have. And then the barriers are life. Life happens. Things happen in life. And the other thing that really happens is that our patients really want to have the best, most normal, most productive life they can. And caring for that chronic illness is a part of that. It's a really important part of that. But we still have to make a way to fit that in and do everything else that you're supposed to do and want to do. So here's some fun quotes about growing up that I found. Childhood and adulthood were not factors of age, but states of mind. I know there's many children who have old souls. My husband jokes that he was an old man by the time he was 15. I think he's right. And then there's many adults I know who really somehow got arrested at the toddler development age. And then there's all of us in between who have the child inside of us, but really there's a lot of things that go into growing up. It's not just chronological. Then there's I'm older today than yesterday, and therefore I must be more mature. And then I would have given anything to keep her little. They outgrow us so much faster than we outgrow them, talking about our children. I have a 4-year-old. My husband always asks, why can't you bring something home from the hospital to stop her from growing up? Isn't that why you work there? No, she keeps getting older. So, from child to adult, many assert that kids are growing, intellectually, kids know so much more, and they're so knowledgeable, but emotionally, there's been developments that actually in some ways stunt the development of our kids. And I have this picture here of two parents holding on to their kids so they can't grow as they're trying to go to school. I vacillated between this and the picture of a helicopter parent hovering over their kid. And, you know, many of our kids, we have these great relationships with our kids, but sometimes it's very hard to let that child grow up and do things on their own. With any kid. Then you add in a chronic illness, and that adds a whole new level, because as a parent, you've been for so many years taking care of your child and doing everything for them. And then they become 18, and suddenly that's a negotiation about how much you do, how much your child will let you do, how much you want to do. How much should the child really do? At some point, I tell parents, you cannot call to make your child's appointment. Your 29-year-old needs to call themselves. And you laugh, but I get varying ages. I get some kids, the minute they turn 18, that parent's gone. I never see the parent again. Because in the way that they've set up is that the child comes in now by themselves, and they handle everything by themselves. And then I get some families where I still have the parents calling me, and the child is, well, as long as you're my patient, you're always my child. For me, even if you're in your 50s or 60s, that's my rule. But for many of our patients, for their child, they're really adults. And sometimes Dr. Coates and I find ourselves in the team working with the parent to try and help them disengage a bit more so that that young adult can start to take on more responsibilities. And it's something that really shouldn't happen when the child is in their 20s. I joke about that. It happens still a lot. We'll talk about how we really want to start encouraging that from much younger. so that when the child becomes 18 and the legal burden is on them, they're much more ready to take care of that. That doesn't mean that the parents go away. Your family never goes away. Though I've had some parent who yelled at me on the phone one time, this was back in Canada, and was yelling at me saying, well, the patient's 18. I said, your son is 18. They can do what they want to do. Well, I'm sorry, that should be illegal. I'm sorry, but that is legal. And they were very upset by the fact that, they no longer were calling the shots with their child. That shouldn't be something that comes as a surprise when your kid's 18, that they have that kind of, legal ability that they didn't before. This, again, transition is a process. So it's a conversation we always want to start early. And then there can also be a delay in independent milestones. And it's not just in our chronic care population that kids, it used to be you turned 18, you went to college, once you graduated university, you went and got your own apartment, you lived on your own, and you do all this stuff by yourself. Very much more so, kids are having a hard time finding jobs. The unemployment rate is much higher in the youth, and so kids, young adults, are living with their parents much longer than they ever did. And there's a delay in that ability to meet independent milestones that there used to be a bit easier. And that's without adding a chronic illness. So it adds another thing into the mix that we have to take into account. So the milestones that we talk about, graduating school. We have at Children's, we have the STAR program, and we have our lovely social worker, Michelle, who's at the back of the room. Many of you know her. And we always, if there's ever any problems with school, we want to know, and we can help with that. We want kids to graduate school on time. There's really very little reason a thalassemia patient who does not have major complications should not be graduating school on time. If you want to go to college, you should go to college, if that's the right decision for you. But it adds an extra layer. Where are you going to go to college? Are you going to go in California? If you do, and you're on state insurance, that's great. Your insurance will travel with you. You're going to go somewhere near Oakland? Great. We happen to know a center up there. I can transfer your care up there very easily. Between semesters, you can get your care here and there. That's no problem. What if you're going to go right in the middle of the state? A few less centers around there, but I probably can work with you. But what if you want to go out of state? Your insurance might not transfer. Are you going to be able to get insurance there? What if you want to go to a flyover state? I have nothing against flyover states, but they don't have centers there. And it might be harder to find someone that we can work with so that you can get your care. It's not that it's insurmountable. It just adds an extra layer of complexity to when you're making these life decisions and when you're looking at colleges that somebody else might not have to deal with. I have patients who go to college all over the place, and it's great, but they had to do some extra legwork into making that happen. And we had to do some extra legwork to work with them, and which we're very happy to do. It's just something else to consider. Work, moving out, dating, marriage, and kids. You should be able to do all of this and do it as it's just a matter sometimes of finding the balance. In dating, when do you tell somebody that you have a chronic illness? Do you tell them? These are all things that you have to figure out and manage. And then having kids. This used to be something that wasn't as much an option for thalassemia patients. And I start having this conversation with kids and teenagers very early. I want them to have that option. I want to chelate them really effectively. This is one of the reasons that we chelate them so aggressively, to maintain their endocrine function and preserve their quality of life. And quality of life is the ability to have kids if you want them, and you're able to. You might need extra help, but I want people to have that option. And I want to have a conversation with the patients about that so that it's not a surprise whether it's difficult, needs extra work, or it's something they can do or can't. This needs to be a conversation that goes on, and it's part of transition. And then managing your own health care. At a certain point, you have to be able to manage your own health care and not have your mom or your dad do it for you. So where do you get your care from? There's only about 1,000 patients. We have 6 CDC-funded centers and other centers as well. I was going to put up a map that I found from the Cooley site, but for some reason, every time I transferred it to this PowerPoint, Oakland kept dropping off, and I didn't want to offend anyone. So there's many centers. There's a few centers around the U.S. Many people live in states where there aren't centers, so they come to see us once a year or twice a year in major centers. Very few adult hematologists have experience with thalassemia patients. Many not offer state-of-the-art care. You guys know all of this, and it needs to be considered when you're going to move, where you're going to get your care from. And part of that conversation is, how complicated or a patient are you? I have some patients who could move to a small town, be co-managed with an excellent family or primary doctor, and do very well. I have some patients who have very, very special needs and have tried to move to those small towns. He knows who I speak of. Dr. Coates looks at me, and frankly, it's not possible because they have maybe really hard, their blood is very difficult to get because of cross-matching issues, or they're on very rare medications that can't be managed. So these are all kinds of things, though, for transition, as you're transitioning from childhood to adult, college, moving out, having a conversation with your providers from the pediatric, what are your options, how complex is your care, so that you know about that, so that when you want to make that transition, you know what you need and what you need to look for. And again, we're here to help you every step of the way with that, but you still have to know yourself. What kind of insurance do you have? This has been changing a lot in California. Patients who used to be able to come see us suddenly get turned away because of their insurance. Usually, Children's, we're really lucky. We have amazing financial counselors who are really savvy about all the programs and know which ones will allow the patients to come see us. So often might be only a temporary disruption in care where the patient can't get authorization, but then we manage to get them switched or they do magic, and we get to see them back again. But it's something that has to be considered. Do you have private or government insurance? What are the age cutoffs? Is it 21 for CCS, then you have GHPP, 26 for coverage under your parents' plan, if they have private insurance. Does your insurance travel? I want to go to school out of state, but will my insurance travel there? If I can get state insurance there, how long does it take to get in to activate? Some insurance payments, you have to be there like 3 months or something. Maybe you can get student insurance, but is it going to cover everything? Often the student insurance plans are more general basic care. Will it cover your chelators? The drugs you take to keep you healthy are life-sustaining and vital, but they are not cheap. And sometimes with different insurers, they might cover your health care, but not your chelators. Or maybe they cover it, but it's covered, but it's on a second or third tier. Do you know what that means? That means big copays. They cover it, but there's all these copays. If you do, then you can get, sometimes there's different foundations that can help you. But this is just some of those bread and butter and logistics things that you have to take into account. It's not fancy. It's not, it's tedious sometimes. And in different centers, people are going to know more about it than others. Because I help the patients a lot with this kind of stuff. Michelle and I are very knowledgeable in this. And we have financial counselors, but some people, it's what is your knowledge base. And I get authorizations for these chelators all the time. So you get used to what will cover it and what won't. When you're interviewing for jobs, what kind of benefits do they offer? I mean, I always ask what kind of benefit. Well, I haven't interviewed for a job in 17 years. But, I ask for, and I'm not going to interview for another one until. So you have to ask what kind of benefits. What kind of health care do they offer? Will that cover going to the center that you're already at? I have some patients who have entered into they got PPO insurance. Everyone's like, PPO, that's the bomb. That's the best one. Then they got the copays. And every time they came in for a transfusion, they're getting hit with copays. And for their x-ray, they're getting hit with copays. And that adds up. Yeah, you got the freedom to go wherever you want to go, but you pay for it, and it's copays. And so I've had some adult patients who are now, they're excited. They have a job, and they're supporting themselves, and they're living on their own, and they're really getting bogged down with some of these copays. For some of them, they've been able to get GHPP, guided through our financial counselors, which has helped with some of those copays as a secondary insurance. So you really work with your financial counselors to find out the best payer mix to cover your insured needs. We still have GHPP. I don't know how much longer for, to be honest. And it doesn't cover what it used to, but work with the financial counselors and your social workers to try to figure out what the best options that you have to reduce some of your out-of-pocket costs. So, what kind of transitions are there? So about 18 million U.S. adolescents ages 18 to 21 are moving into adulthood and will need to transition from pediatric to adult-centered health care. And that's just regular adolescents, regardless of whether you have a chronic illness or not. And there's different types of transition. There's where you transition all your care to an adult provider, where you transition to an adult model with the same provider, and then transitioning to an adult provider with continued follow-up with your thalassemia center. We like number 2 and 3, to be honest. That's our favorite kind of non-transition transition of CHLA, as we call it. So what's the difference between pediatric and adult care? Obviously, in pediatric, parents are in charge. In adult, the care is self-directed. This is where sometimes we get some conflict between the parent and the child and the dynamic, and between your nurse practitioner, because I really do strongly believe that adults need to learn how to direct their own care. And so when I start getting parents calling me to make basic appointments and stuff for their child, I really discourage that. And at some point I will say, your child, your daughter or son must call in to do their own stuff. They must take over their health care, because I really don't think it's beneficial if the young person doesn't learn to direct their own care. The care in pediatric, the care is monitored by parents and healthcare providers. Obviously, it's self-monitored, supported by healthcare providers. We support care. And an adult model is a very different model. And in pediatrics, we we support a lot, because we always want to do what's best for the patient and the child. And in adult, they have the same philosophy. They always want to do what's best for the patient, absolutely. But they're not going to overcompensate or manage. In pediatrics, we always, if the parent's not showing up, we'll give you lots of chances, because we want what's best for the kid. We don't want life and all of its stressors to get in the way of the kid getting their care. So it's a different focus. But in adult, when you're in charge, they're not going to call you to reschedule their appointment. They might not nag you like I will. And I'm a very good nagger, as Dr. Coates knows. You know, they're not going to remind you to show up for stuff. They're certainly not going to send a taxi to your house if you can't get there. Maybe if you're lucky, you'll get a bus token. And I've had many an adult patient call me very upset with the emergency room at a different institution because they didn't give them a taxi voucher to get home. They only gave them a bus token. And I had to say, I'm sorry, but that's adult care. They don't have the same resources, and it's a different philosophy. And for many of our patients, it's hard transitioning from pediatric. It's hard growing up, period. And with the chronic care, that changes as well, that philosophy of the healthcare providers. We will schedule your appointments to you. We will remind you about them. You get a courtesy call reminding you for your appointment in adults. Many of us do. But if you don't show up for that appointment, nobody's going to hunt you down. And so the onus really goes to the patient to be self-directed and make sure that they get their care. So then what you have to do is prepare that person for that job. It's a job like any other job, in advance, and not just foist it upon them and them not be prepared for those responsibilities. We offer so many services. In adult care, you have to go out and seek them yourselves. You have to be very proactive, and you have to be your own advocate. As a child, your parent is often your effective advocate, but when you seek out adult care as an adult, you must become your own advocate. You have to provide your own transportation, and any request for treatment and outcomes, you have to ask the questions. How is this treatment going to affect me? What are the outcomes? Your parents aren't going to do that for you. So you have to stop being an observer in your care, which many of our kids are. We sit there in a provider room and we talk to the parents about what's going on. And usually, often the kids just kind of sitting there. And it's very important that we engage those kids early on so that when it's time for them to be the active participant and not just the observer, they're prepared for that. So, finding a provider. A lot of this information right now is from a really cool website called Got Transition. It's gottransition.org. It's what we've been looking at our transition model from. You can see it on the website. I should have put Sorry, I didn't put the address on, but it's really gottransition.org. If you just type Got Transition, you can find it really easily. And they have a lot of good tips and tools about transition and everything. And we've been getting a lot of our inspiration for how we do transition from them. So finding a provider. Ask your current doctor for a referral. This is my #1 recommendation. The thalassemia world is small. There's not a lot of people in it. At Children's, we know all the other major providers, and also we're really actively building up a partnership and a network of providers and adult physicians in our area and even some out of state in some different areas that we have worked with in the past that we know are open to a collaborative relationship and are beginning to get some experience and showing some interest in caring for thalassemia patients. It's much easier to start with them rather than reinventing the wheel and starting fresh with someone new. It still can be done, and we are open to having a relationship with any provider that you go to. But we know that some we just already have a relationship with, so it works well. Another thing is you often do have to call your insurance company, because I can know Dr. Smith and he's the best adult doctor I've ever worked with and he's awesome, but if your insurance doesn't cover him, then that's not a viable option. Check with your local support groups. Thalassemia Support Foundation, Cooley's Anemia. They know a lot of doctors out there who have interest and have been working with thalassemia patients. So those are all great resources. The other one, this is something from Got Transition. It's very hard to cold call an institution and say, do you have anybody there who knows anything about thalassemia? The referral line might not know. But if you're going someplace and you call and they give you some names, let's say it's someplace that we don't know anyone, but if you call and get some names, we actually might know them. We don't know that they have interest in thalassemia, but like Dr. Coates is really well connected with the hematology community. All of us are. So we know a lot of the providers out there because you see them at meetings and stuff. So we might have a relationship that we didn't realize that person was a doctor there. Does that make sense? We don't know who we don't know. Questions when looking for an adult provider. So things to talk with the office, and some of these things that you can Google and find out ahead of time by doing research online. Do they accept your insurance? Are they taking new patients? Is it accessible? What are the office hours? I would add to these questions, how do they do their transfusions? Do they have a separate infusion center? How many hours is it open? Is it like Cedars has a 23/7 infusion center, which is really nice for our patients because I'm sad to say that here we do Monday to Friday. And if you're trying to have a job, which most of us want to have, or college and stuff, it might be good to find a center that can transfuse you and be very flexible. The trick is a lot of adult providers want you to see them before their transfusion. Here, we only usually see you every 9 weeks. We order transfusions in between. But a lot of adult places will want to see you and then do the orders. How efficient is that? How flexible are they on that? These are all kinds of questions if you're trying to find an adult place to get your transfusions at that you need to know. When you're talking to the doctor, one of the things you can have when you're talking with them, you can say, like, I still go to Children's for my adult care once, twice a year. I would really like it if you could work with Dr. Coates and Susan. This is something that would be very important. Would you be willing to do that in a very nice and polite way, of course? Asking where do they schedule appointments, the kind of infusion center do they have, where do they admit to, and who else is on their healthcare team in that office? Do they have nurse practitioners? Do they have PAs? Do they have social workers? A lot of times they're not going to have a big team there because private adult care is very different. And even when you go to an academic center, they're still not going to have the same resources probably that we do here. That's just the way it is. So ask yourself when you're visiting with your physician and your team, are they listening to you? Are they answering your questions? Can they explain it so that you can understand? Do you have confidence in them? Do you have faith in them? Do you think that they would work with us or another provider if you want them to? Are they treating you with respect? These kind of seem basic, but a lot of times with our insurance, we get shuttled off to a doctor or a provider, and you also have to have a good therapeutic fit. Not every patient and provider is going to have a good therapeutic fit. Some people get along well, some people don't. It's important that you have trust in your provider and that you have a good fit with them and that you can feel that you can answer them. ask some questions, get good answers, and question what they're saying, because we don't know everything all the time. So one of the things that the nurses in the thalassemia program, or the thalassemia centers, got together, and we put together some guidelines and education for the thalassemia transition program. Some of this stuff is stuff that needs to go to your provider if you're going to be transitioning to an adult provider, or even getting part of your care. When I say transition, that doesn't mean moving over completely necessarily, but again, maybe you're going to be seeing an adult provider for your transfusions. And some of these things that you need to know, and some things that, like if you go see somebody else, I'm going to be putting together in a packet for you and in a letter. But a lot of these things you really need to know. I get patients come see me all the time for a comprehensive evaluation, a second opinion. They come to see Dr. Coates and I, and sometimes they bring their families with them, their parents, which is great, because I'm sitting there asking them, okay, how old were you on transfusions? And they'll go, oh, Mom, when did I start transfusions? And because they don't know this stuff. And it's really important to know, because that's part of, like, when I'm assessing you for stuff, I ask every question for a reason. I want to know when you started on transfusions, because I want to know if you were a flat-out Thal major, or maybe you were more towards intermediate. I want to know what your baseline hemoglobin was prior. You might not need to know your exact genetics, but it's not bad. Like, when I give DNA results to my patients, they could have it in their file, because I think it's a good thing for them to have. If you're non-transfusion dependent, I'm sorry, my bullet got moved over. Again, you should know how often and what kind of specialty appointments you go to, frequency of labs and imaging if you're transfusion dependent, again, your type of appointments, your blood type and antibody status. Ideally, the other blood banks should be talking to my blood bank, because there's stuff that go along with the transfusions and the blood preparation that they need to know. But you should know, what is your blood type. Have you ever had a transfusion reaction? Do you get pre-medications? Why do you get pre-medications? How much are you getting at each transfusion? And what's your baseline hemoglobin? These are all things that you should know as a patient, so that if you're transferring your care to anywhere else, that can help transfer that care so that they can transfuse you in the same way that you were transfused before. Iron overload. When was your last imaging? And, of course, we would do MRI. What are your ferritins? What do the results mean? You should really know what your numbers are. You don't have to know every number every time, but you should know how iron overloaded you are. You know, is it in your heart, your pancreas, your liver? You should have a good knowledge of these kinds of things as part of knowledge of your own health care. And then the complications that you have, the available chelators, what's worked for you, what hasn't. All this will be going in a letter, ideally. But a lot of times when patients come to see me, like for a comprehensive evaluation, they may never have been to a center before. And so a lot of this stuff that is not coming in a packet, it's coming to me by history. And I'll tell you a secret, a lot of times we send a packet. Providers don't always read every word in that packet. They're going to be relying on you to give a history. So it's very important that a patient know their history. And sometimes because their parents have been their historians all along, they haven't learned that history themselves. So it's important to teach it to them. And part of that is me teaching it to them and Dr. Coates, and part of that is as a parent teaching that to their child, that they know their own stories. Part of transition to care, accessing care, how to make their own appointments, who to call. That seems obvious, but a lot of patients don't seem to know, again, how to pick up a phone and call me to make an appointment. So that's something that they need to know. Prescriptions. Many patients don't know where their prescriptions come from. They don't know who their specialty pharmacy is. And that's really important when you're trying to transfer care, because there's a lot of different specialty pharmacies. It depends on insurance. Who do you get your XJ or your Fairprox is only one pharsmacy, or your Desferal? Who do you get your chelators from? Who your insurance is, how to contact them, who your primary care provider is for your non-thalassemia health. You do still need to have a PCP. All the emergency care plan, and then life skills, your education goal, career goal. All these kinds of things are really important when we're looking at what kind of work resources are available for you. You know, there's FMLA, Family Medical Leave here in California. I'm filling those out all the time for parents. As a patient, you're eligible for that too. You have protected time to come for your transfusions. Some of the resources that are out there when you get to an adult place, you might not have the same social worker like Michelle telling you all these resources. You have to be very self-directed and get them yourself. We can help you. So let's start giving you some of those tools as a kid so that when you become an adult, you're not flying blind. So when should we start? Transition is a process. It's not something that happens overnight. It's emotional, intellectual, and physical maturation into adulthood. And there are goals for the patients, the parents, and the providers. These are all goals, and we're trying to build checklists, but there's all these things that we can do. And it doesn't start at 18. Really about age 12 to 14. We like to work with the patients, meet with their medical team alone to ask questions. We want to kick the parents out and start asking the kids questions. And sometimes it's just normal teen health behavior. Other times it's how are things going, and ask them questions about their health. Set their own health goals. Develop independence in managing their health care. That means you start encouraging. That doesn't mean at the age of 12 you say, okay, you're responsible for taking your X-Jade, go. I've seen families do this, and it ends up in disaster. Because eventually, sometimes the kids, they're not ready for that yet. But you start teaching them how to mix it up yourself, teaching them more about the times that you take it. Start talking with them more about, hey, we're going to go for your transfusion today. Here's why we go every 3 weeks. You can tell them what you're doing to coordinate their care. I'm working with on a project with Cal State San Marcos. We're developing an app for thalassemia patients for ages 12 to 18, and it has reminders on it of taking their medication. We set reminders to see if that's something that might help improve compliance and getting them engaged in their health care. So when that rolls out, some of you will be talking about that. We're hoping to roll that out in the fall. We're going through app development right now. But there are ways to get kids involved in their care, find out what works with your child, and start the process of talking with them. It's, again, 18 is not a magic number. In some ways it is, in some ways it's not. But you can't expect suddenly a kid who's not prepared at 18 to do everything themselves. For the providers, we need to educate. Really, you sit there and you talk with the parents, but really turn to the kid in the room and saying, okay, do you know why you get your blood? Why do you come see me every 3 weeks? Your friends at school don't have to come to see me. Do you know why? And I've been met with some big blank stares. And then when you start talking, and it's okay if you don't know. It's not a quiz. You're not getting graded. But let's start talking and really talking with them. What is thalassemia? Why do you get blood? Why do you have to take that medication every day? Because of your iron. And really getting them involved and knowledgeable about their care. And then seizing on that teachable moment. I had one young man who, in the middle after seeing him, suddenly turns to me and says, I'd spent a long time talking with their family, and then I looked at him and said, any other questions? And this is my favorite healthcare question of all time. He said, Susan, when there's a zombie apocalypse, will I be able to live without my transfusions and chelation? And I said, that is the best question ever. Yes, and for him, because we had a special, you know what I took that as? This young man wants to know about his disease. And so I sat down and we had a really good conversation about why he's transfused, why he needs the X-Jade. And then I brought in his hematologist who also thought it was like the best question ever. And we came up with strategies to help him. But it was showing interest in what he has. So you seize upon that. When you have that interest, and that's as a parent or a provider and your kid's asking questions, talk about it with them. And then when they glaze over, you stop. When we all glaze over. But you have to seize those teachable moments. Ask them about their hopes, dreams, goals, and fears, their friends and their peers, about school, relationships, and risky behavior. Sometimes because we know the kids from when they're newborn, it's hard enough for you to deal with them growing up. It's also hard for us to deal with them growing up. And I have one adult hematologist who works with a few of our kids still, and he's also always thankful when I go in and talk to the young ladies because he doesn't like to have that kind of talk with them about young lady stuff. And I'm comfortable having it with them. Just like I know some of our young men like to talk more with my male physician counterparts. But you have to have that conversation with them because that's all part of growing up. And it all works together with their thalassemia as they mature into these young adults. I had one young man who's, I never knew, had this insane he was really terrified about being short. And he ended up, I was talking with him about, we had measured his growth hormones, and him and his mom just started, and I said, you know what, we can do this, and we can treat you for growth hormone deficiency. We're going to refer you. And him and his mom started crying. And I looked at him, and he goes, I never thought I could grow. And I went, that's why you spike your hair, isn't it? I said, yeah. And so it was a hope and a fear for him that was very important. And being able to have that conversation and then treating him for it, you know, getting him through adulthood. Now he's a young man who's going to get married soon, hopefully, and wants to have kids. And being able to have that conversation with him and encouraging him and nurturing him as he grows. Still ask how your parents are, but I never get to see his parents anymore because now he's taken over his care and he's very competent dealing with it. Our transition goals is that by the time a child turns 20, or sorry, a young adult, we're going to work with our patients to find them an adult primary care doctor, though we're hopefully going to continue to see them for their blood-related disorders. At Children's, we've been very lucky. We can grandfather in our patients and still transfuse them in our infusion center, though if new adults come to me, I cannot transfuse them there. But I happily work with any adult physician that they have and create a partnership and a collaboration so that we can work together to get the best care for the patient. We are creating partnerships with our new adult primary care doctors by giving them the patient's health care summary, medical records, and communicate with them about their patient's unique needs. Now, a word of the wise. If you call me on Monday and say, Susan, I'm going to go see my new adult doctor, it's on Tuesday, and I need everything sent to me, I will very kindly and gently tell you that that is not going to happen, because I cannot get a whole history together in one day, because often there's long stories that have to be told, and it takes a while. So you're going to want to work with us well in advance. And I know that what we've been creating at Children's is a list of the patients and who's getting near that we really have to get something set up right now, who's got something gets set up in the future. So again, transition is not something that just happens overnight. We're working on it and setting priorities. 18 in some ways is a magic number, in that that is when the patient is old enough to be able to legally consent for themselves. They're also old enough to say, I don't want you to talk to my parents anymore. And I have to abide by that. They're also old enough to say, I would like you to talk to my parents. And so we'll get consents, because 99% of the patients have no problems with us talking with the families. Usually, though, there are a few. That's their decision. We do encourage, there are some patients who, for various reasons, might not be able to take over their own care when they turn 18. And legally, there are things as parents you can do, conservatorship, power of attorney and stuff to help keep watch over them and to preserve their care until maybe they're old enough or at a point where they can take over. And we can work with you to help make sure that those legal guidelines are in place to protect everyone. 21 is not so magical an age. Yes. Oh, 5 minutes. Oh, I thought you had a question. You're no longer eligible for CCS, but you can apply for a GHPP. And in the way it's not magical is that you can't be admitted anymore at Children's Hospital. There are very rare cases where we can, but for the most part, we can't admit you anymore. So even though you can come see me, our clinics have no age limits. Trust me, I'm a pediatric nurse practitioner, and I have 58-year-olds lately that I'm seeing. Our clinics have no age limit, but our hospital does. We can infuse you or transfuse you, but you can't be admitted. So you have to have an adult place, even if you still come see us, where you can be admitted if need be. And we've been working with the patients to make sure that happens. Now, one model of transition, which we've been doing for many of our patients at Children's, is we have a network of adult providers the center has relationships with. The adult patient has a primary adult hematologist who orders their transfusion and chelation. And we have quite a few patients who we see many times a year who have this. The patient comes to a thalassemia center once or twice a year for a comprehensive evaluation, including the MRI, because many adult places cannot do MRI for reasons that Dr. Coates explained. And there's a close collaboration between the patient, provider, the adult provider, and the thalassemia center. And we can offer support for the adult provider. We have several adult providers that really want to take care of our patients, and they're great to work with. But they don't have Michelle. They don't have me. They don't have an office staff who can really help them with stuff. So they'll email me and they'll say, so-and-so needs an MRI. I'm like, no problem, and I'll set the MRI up for them. Maybe they have patients who are on Faraprox, which is a little tricky to order, so I'll order the Faraprox for them. And we do everything we can to help support them because it's a collaborative relationship. And it's really working out with some of those patients. So for some of our young adults now, if they, once they get college or work and they, for whatever reason, they don't want to be transfused at CHLA, or maybe they can't be, we still encourage you to come back and see us. And if you stay in the LA area, we have a network of adult providers who would like to introduce you to. It doesn't mean you have to leave us altogether. We would like you to come back and see us, and we want to work with those providers. In summary, I am right on time. Transition is a process. It's very different for every patient. There's no one cookie-cutter transition plan that is going to work for one person and the other. It's really very different depending on what your goals are, your hopes and dreams, your insurance, all those things that we talked about. It's going to be stressful, but it can be very exciting as it's complicated. We are here to help you get through that and to make sure that it's as successful as it can be. And you have to remember that you're not alone in all this, that there's also a big community out there. It's not just us at Children's. You've got TSF, you've got Thalassemia, you have all these people out there who want to help you succeed. It's trying to tap those, making sure that you tap into those resources. And the secret to change is to focus all your energy not on fighting the old, but on building the new. Having said that, now you understand why Peter Pan didn't want to grow up. Thank you very much for inviting me to speak. I hope this was educational. And does anybody have any questions? Transition's not as fun as standards of care. Yes. Absolutely. I will repeat the question. What the question was is there if there's an adult patient who has not been at Children's and can't be grandfathered in for their transfusions, can they still come see us for once a year or twice a year for a comprehensive evaluation? And the answer to that is absolutely. We get referrals from adult patients from all over the country, sometimes all over the world, who come see us. We'll set you up in our clinic for an MRI. I'll devote 3 hours of my life to do a comprehensive evaluation and sit down and come up with a plan and recommendations that can be taken back for your provider, your adult provider. Then what we like to do is often Dr. Coates and I will try and arrange a conference call with your provider, if they're open to it, where we can just have a conversation with them, go over what we recommended, see if they have any questions, offer our services to help them out. So we do have many patients that we do these evaluations with. The other thing to know is that you get a copy of that report and that letter. We do that with all of our referrals, period, but I think it's important that you know what we recommend, so that also if you need to go to another provider, that's part of your history. I encourage patients to have their own copy of their key medical records to take around, because the reality is people usually don't stay with one doctor or center their whole life. And be the keeper and the curator of your history and be able to take it with you. But absolutely, and if you'd like to come see us or anybody wants to come see us, I encourage you to give me a call. There's my information. Yes.
Is the app that you're developing going to have the capacity to put medical history in it?
Not at this point. Right now, we are a small group of nurse researchers with no money. So right now the app is designed to look at compliance with medications. So it's going to have the nurse will program in what's your medications times. It's to teach young people about what dose am I taking at what time and to see if that helps them. We're going to be piloting that out. You know, call me old-fashioned, but before I would put any kind of your health information up in a cloud somewhere, you might want to really check the security of that. So no, we're not going to be putting any health information out there. for various reasons. One, we don't have the resources. Two, we're very fussy about what we put out there in the cloud. Yes. Anything else? Yes, Mr. DeLorenzo.
So the third model is what I'm asking about. So you have an adult provider, hematologist, internal medicine that's local to you, and then, once a year the person goes to, you guys to kind of get the comprehensive care, do the MRI. How well has that been working in the past 5-10 years?
I think it's been working pretty darn well, and especially, and it's gaining momentum. We're getting more patients, and we're expanding our repertoire of physicians that we refer to. A lot of that is, I think, that we believe very strongly with this, and we do everything we can to nurture the relationship with those providers. And for the most part, they've been very amenable, because a lot of them just, the ones that we've been working with, realize that they don't have the same expertise that we have, because we're not sitting there just telling them how you should take care of your patient. We're very careful in the letters and reports that we write, that we're not just telling you, Dr. Smith, what to do. It's, we would recommend, and we put a lot of thought into when we're explaining what we do, and then we actually have conference calls with them to converse. And a lot of the patients who come to see us, I had one young man who, unfortunately, due to insurance, was literally ripped away from us. Suddenly he was changed to an adult provider he went from having a hemoglobin in the 10s to a hemoglobin in the 8 pre-transfusion. And he was trying to go to nursing school, and he felt like crap because his hemoglobin was so low. And this physician, very nice guy, but most adult providers treat leukemia and MDS patients. They don't treat thalassemia. So he was going by what he had learned, is that you keep the hemoglobin low to spare the iron. And so we worked with him, and now they do keep their hemoglobin not very high. We still see him once a year. We didn't try and we made sure they didn't feel like they were trying to steal him back or take over his care. That was truly a collaborative partnership. And it's going very well for that patient. We had a conference call with him. One of the other challenges that you can get when you go to an adult provider, which I forgot to mention, is that some adult blood banks have cutoffs of when they're going to release a unit. So they won't release a unit if the hemoglobin's above 10. And we had one where we sent somebody to an adult provider and they wouldn't release a unit, and what it took was getting the director of that blood bank on the phone with one of my hematologists to explain why we still wanted to transfuse a patient even when their hemoglobin is 10. So sometimes it takes a few visits to kind of get them where we need to be, but for the most part, we've been very successful in working with these patients, with the providers. And then they also know that they can email me and bug me, and I go out of my way to help them because I want to. It helps with keeping everyone happy. So, yes. Did that answer your question? Thank you.